Let's move on to the next speaker. It's my great pleasure to welcome Professor Barry Smith, who is a distinguished professor of philosophy and director of the National Center for Ontology Research at the University of Buffalo. He is recipient of the Wolfgang Paul Award from the Alexander von Humboldt Foundation. He received the first Paolo Bozzi Prize for Ontology from the University of Turin, and he is elect fellow of the American College of Medical Informatics. He has authored and co-authored over 500 publications, including 15 authored and edited books. So by the sheer volume, of his academic output would justify his presence at this conference of big data. His research is focused on ontology, especially on the application, especially is on the bioinformatical, especially applied to the electronic health records, which we will talk about today. So please join me in welcoming Professor Barry Smith.
Now, the glory, I think, is fairly clear. If we have electronic medical records in our hospitals, then we can avoid redundant tests. We can improve continuity of care, because when you move from one hospital to another hospital, the second hospital will have all the data about you that was collected by the first hospital. We can also improve the quality of information, so people will not lose or burn pieces of paper, and they will not be troubled by ineligible handwriting or by non-standard codes or abbreviations. Typically doctors will point in the corner and say, "Give third breast this," and what they mean is the third bed with the breast cancer patient on the left-hand side of the ward. Now, medical health records give us better information, which is also more easily accessible to patients themselves in principle, but certainly to multiple doctors and multiple labs and so forth. They enable more efficient transfer of information. They enable e-prescribing and so forth and so on. So they're all clearly wonderful things. But even better, they said, and this is 2005 in the United States. I'm going to talk about the United States, but very similar phenomena to the phenomena I'm going to describe happened in other countries as well, even more gloriously and miserably in the United Kingdom. The United Kingdom had such a good system of medical records for the whole country that it failed twice. And cost $120 billion in the end. So, in the US, the vision was that they would save $77 billion annually by introducing electronic health records. Again, this is in 2005, and this is surely glory. $77 billion annually. That's what they said. And then certain things happened, which we will soon be describing. Now, the misery turns on two factors, primarily. One factor is the need for interoperability, and the other factor are the costs of healthcare records. So interoperability means that two systems can talk to each other and share data in some genuine sense. And as David Brailer, the person who launched the huge effort to install rapidly electronic health records in American hospital systems, admitted, all of the benefits of electronic health records work only if you have interoperability. And today, you still don't have interoperability. Now, it's a problem. The reason why we don't have interoperability in the US is because we have multiple vendors who sell electronic health record systems and who make their money by the fact that they, in effect, have control over the data inside those systems. Other people can't help to tweak the system so that they work better for your hospital. You have to pay the vendor each time you want to make a local improvement. Other people can't use the data, except under very special circumstances and typically with a great deal of manual effort, without the help of the vendors of the electronic health systems. So they control you. You have mortgaged your data to this particular healthcare record vendor. This is just a few of them, and all of these are competing with each other, and all of them have walls around each other to prevent interoperability with the other systems. Although if you go to each of these systems' websites, they will explain that they do have interoperability. So they claim that they do, but in fact, when you examine, and when other people have examined the situation, you don't have interoperability at all. Now, one dream of this lady, for instance, is that we will solve the problem of interoperability because only one system will remain and all the others will die. And this system will be called EPIC. Everyone will use EPIC. So in America, EPIC has the largest market share, and it seems to be rising each year. Not because EPIC is the best, it's not the worst either. Even if it was the best, that would not imply that it was any good. But because it's the biggest in two senses. One, it has the most customers, and so people feel safe. The other is that it has all the bits you need for billing, prescribing, and so forth, lab tests, where some of the other systems have only certain bits, and so you have to create plug-and-play combinations. With EPIC, you get everything, and who wouldn't want everything? And EPIC is now spreading its tentacles out into other parts of the world, and tomorrow, who knows? So the headquarters of EPIC is called EPIC Intergalactic Headquarters. 1979 Milky Way. Now, the problem is that even total victory of EPIC across the entire galaxy would not bring interoperability. Now, first of all, EPIC is a closed system, which makes it hard even for hospitals using EPIC to interconnect, whatever they say on their advertising. But secondly, even within a single hospital, EPIC data is not necessarily interoperable, because different parts of a hospital may have local codes, which EPIC has generously, at a price, installed. And the training may be different in different parts of the hospital, so that they use EPIC differently in different parts of the hospital. And repeatedly, one finds that even people working for the same organization using EPIC cannot share their data. Now, this costs money, $700 million for an EPIC system in one health system. This is the initial cost, and then you have the cost each year, each week, maybe for local tweaks. Sometimes it's even worse. So the first installation of an EPIC system in the UK, in Cambridge, cost £200 million. And it broke and wrecked the systems in the hospital. So the ambulances were being sent to the wrong place. Hospital consultants were issuing notes to blood transfusion and pathology services that didn't make any sense. The finances of the university got into trouble, and EPIC was blamed. The organization failed as a result of the installation of EPIC. They crashed the hospital. That's a cost. There are other costs. You have to train everybody to use your new EMR system. They all have to change their working practices. The time to feed the EMR system is time which would otherwise go to patient care. I've already mentioned the cost of local tweaks. In many cases, you have an additional cost that people get so angry with the electronic health system that they force the hospital to buy a new one. And then you have to start again from scratch until people get angry with the new system. And then finally they buy Epic, and then they are lost forever. There is something called alert fatigue. Pieces of paper don't give you alerts when you write the wrong thing. Medical record systems often give you too many alerts. And so there is the tap-through syndrome, which presumably causes also osteopathic problems. Alert fatigue is a general problem. This is a figure from a paper in the Journal of the American Medical Association. It's a drawing by a 7-year-old girl of how it feels like to be a patient when your doctor is only looking at the screen. So the computer here is becoming the conduit for patient care. So Kaiser, which is a big healthcare foundation, insurance organization in America, did a study of Epic and said that it led to a persistent 2-minute increase in the length of time of an average encounter. Now, that doesn't sound like very much, but if you're a hospital and you have limited resources, then that is indeed significant. Now, all of these combinations, I should say that we still don't know whether electronic health records have saved any money. So they certainly have saved some money. Some things are more efficient. Prescribing is more efficient. They've certainly also saved lives, but we still don't know whether, on the whole, it's been a benefit. The American Medical Association issued a cry for help. They had created a new organization to fight the government mandates for use of medical care, which I'll talk about in a minute. Now, there are 3 reasons for the failure of all of this. One is magical thinking. So, and this is, I have to warn you all, a characteristic syndrome among computer scientists. When a new gizmo is invented, computer scientists think that it's going to solve many problems, and typically it doesn't. It may solve a few problems, but it doesn't solve the many problems that one had in mind originally, particularly if you don't think carefully about what you're going to do before you install your new computer gizmo in every single hospital in a continent-sized country. Another reason is that they didn't check with the doctors who were going to be using these things before they mandated their use. And the third thing was that they didn't test them. So I'm not blaming Epic. Epic is not the worst. So Epic has its problems, but they all have their problems. They all have good and bad. I'm not blaming the United States. These problems have been encountered in every developed country. But in the United States, they were, as in the UK, they were compounded by government mandates. And I could talk for hours about the government mandates. I could literally make your brain bleed by having to read the government regulations governing the use of electronic health records. I'll just give you a little bit of this. So the HITECH Act of 2009 said, let's bribe physicians to adopt these systems, Epic or whatever it might be, the existing legacy systems which had old database technology. They were not particularly new, even in 2009, when their use was mandated. And we wanted to do this quickly. That must be good. And then penalize them if they don't do it. So $27 billion originally, it went up as incentive payments. And then after 2015, penalties if you're not using electronic health records. So you have 4 years to install them. You get money, peanuts actually, compared to the cost, but they didn't explain that. And then you get fined. And then being fined now if they're not using electronic health records in certain mandated ways, which are excruciatingly confusing and puzzling, but I won't go into those details. So, through $30 billion in 2013, People are beginning to notice unfortunate and intended consequences, wrong orders, patient errors, alert fatigue, and so forth. So let's just imagine, in 1959, COBOL was a new, shiny new computer language. Maybe some of you here are too young to have even heard about COBOL. I understand there are people in this room who have never seen a single episode of Monty Python. I've never heard of Monty Python. COBOL was a shiny new computer language. Let's just imagine that this man had been in charge of computer investments in the US in 1959 and mandated that everyone has to use COBOL forever. Now, so why did they do it? Why did they do it so quickly? No one was trained. There were very few people who knew how to build an electronic health record. The ones that were built were, I won't use a swear word, but they were not good. There were no people in hospitals to train people to use them. Now everyone hates them. Electronic health record technology has certainly been set back by at least 5 years by a mandate to introduce them before they were mature, before they'd been tested, and before there was a trained cadre of people who knew how to install them and improve them. And this is before the issue of interoperability had even been addressed, even though it was recognized by the defenders of the High-Tech Act that it was indispensable. The reason is money. On the one hand, people saw a way of getting rich from the government, and the other was that the other reason was magical thinking. They didn't think anything could go wrong. Now, one thing that went wrong is the creation of a new etiology of disease, digitally caused disease. This is not a trivial problem. The Institute of Medicine published a report on health IT and patient safety, which refers to health IT-related deaths. And again, I could talk for hours about health IT-related deaths. Now, lack of training. When Boeing invents a new engine or a new cable connection to the wing flaps, it tests what they introduce. Thousands of hours in all kinds of situations before they install the new invention in actual working airplanes. No testing was done at all on these electronic health records. No preparation was made on the side of the doctors who would have to use them, and so many doctors began to hate them. And many doctors began to hate them because they could see that their use was causing deaths because of distraction of doctors by having to use mandated electronic health records in mandated ways which took time from dealing with emergency patients. Okay, final couple of slides. How is all of this important for computational bioscience? Well, the first reason, of course, is that you're all likely victims of magical thinking. And you should be warned that magical thinking is not a good thing. Secondly, you're all relishing the day when patient genomes will be so easy to produce that every patient will have their genome sequenced as they walk through the hospital door. And I agree that this day is coming. I, too, am tempted by magical thinking at this point. We can replace all those silly old doctors, and we'll just have our computers running over the genome of the patient and issuing a treatment plan. But we're not going to be able to do that. We're not going to be able to cure patients or determine treatments for patients just on the basis of the genome. Even for computational bioscience reasons, we're going to need the proteome as well, at least. But we're going to need a lot more about treatment plans, about problems in that particular hospital, about environments in the neighborhood, about the backgrounds of the individuals themselves. It's not just the genome, it's also the environment. And much of that information is going to need to be available digitally. So we're still going to need electronic health records. Now, we've seen the three reasons for the failure of Braille. We don't want to impose on hospitals immature, untested systems. When we're introducing genomic technology, we don't want to impose on hospitals immature, untested systems. Now, how should they have done it? Well, the answer is clear. Research hospitals and high-tech research institutes like CBRC needed to be testing, designing, honing, refining, user testing new ideas for new systems for several years in a competitive environment to find out which ones worked. And then those that seemed to be working would be tested in ordinary hospital environments, again, in the way that Boeing would test a new kind of cockpit design. And only then would people start to think about generalizing those particular solutions for capturing clinical data and spreading them to hospitals more generally. Instead of placing a government mandate on COBOL at day one, you would allow the market of research organizations to work out those things which are actually going to work. We need to start doing that already. Now, I'm an ontologist. I think that one model solution to this is going to rest upon doing for medicine what ontologists have been doing for biology. Several of the presentations here have mentioned the gene ontology, which is the paradigm example of a successful ontology. I think it's the one thing which is a running thread through all of the talks here, or for many of the talks. We need to have something like the gene ontology for healthcare. Now, we have ICD. Be very afraid. ICD is a world government mandate. It may get better. So ICD-11 is supposed to be ontologically driven. It's supposed to be ontologically driven by the nearest thing to a government-mandated ontology, the SNOMED, or Systematized Nomenclature for Medicine. SNOMED is distinguished by the fact that it has even more funding than KAUST. It has infinite funding. So the 15 countries have mandated that a base level of funding of $15 million, which increases each year, will be guaranteed for SNOMED forever. That's infinite funding. It's still not good. It's using old-fashioned ontology technology in old-fashioned ways, but it's the best thing we have to hope for because the government has already started to mandate interoperability between electronic health records with a little bit of magical thinking on the basis of SNOMED. If there is any government-mandated interoperability, it will be driven through SNOMED. Now, finally, the ontology for general medical science is part of an effort which I'm involved in to try and do this job properly, to build a proper ontologically based basis for electronic health records. I have some friends in the SNOMED community who would like SNOMED to be more like OGMS. They always get voted down when they make these proposals, but gradually I'm optimistic that some of the ontological possibilities which I believe would help the situation will be introduced into artifacts like SNOMED. And that's the end. Thank you.
Thank you so much. So it's safer to fly than to go to the doctor?
I should probably by a very large margin, but that's a question for Andre.
Yes, the question in the back, please.
I want really to thank you to bring our attention to this magical thinking thing. Because I agree, as computer science students and doing research in this domain, we came to the point where we keep thinking only about the data that we have, forgetting about the patients that will be affected by this system eventually. And this is a point that shed the light on maybe the dark side of what they call AI singularity at some point of time. So there is an enemy called psychopath that shows some of that, but here we are seeing some of the facts that you came through. So I would really like to thank you about this perspective of viewing the things.
Yes, several questions down there. Karen, maybe first.
Thanks, Barry. That was interesting. I'm wondering if you have any thoughts on the efforts around the Open EHR framework, which I know hasn't seen wide adoption or interest in the US context, but in other places seems to be gaining ground.
Yeah, so I'm a fan of many aspects of Open EHR. First of all, it's open, so it's driven by other kinds of factors towards interoperability, where the closed systems are pointing in the direction away from interoperability. I think Open EHR is going in the right direction. That's the best I can do. There are still some peculiar artifacts within Open EHR which it seems to me are creating unnecessary complexity. So there are vested interests even in an open community to keep these older things.
Andre?
It's quite a disturbing picture you painted. Well, one of the glorious part, I think, data scientists would really, really benefit from this. And, well, I can't imagine the world where I wouldn't have access to tons of data like this. I think it's, in the long run, it will be really important to have this. My question is, why, well, a lot of things that you mentioned have to do with economics, with politics, right? And to the smallest extent, actually, to philosophy, ontology, and science. So do you think we are, well, we can handle this problem at all?
So most of what I do, actually, even though I consider myself an ontologist working in biomedicine, most of what I do is lobbying. Not lobbying politicians so much, but lobbying other scientists, lobbying groups like this, A, to be warned about what's going on, but also B, to plan strategically how to build the right sorts of antidotes to what the politicians will do. And I don't actually blame Judith Faulkner and Epic and the owners of these companies. I blame the government, because the companies themselves would have had to fight to produce good products if they had not been mandated, if the use of their products had not been mandated at an early stage. So the problems were the government mandates.
Yes,
thank you. Okay, I was thinking that your talk, although you suggest that the problem was EHR problem and computing problem, but actually if we go through your slides, you actually are saying that it was a political problem of implementation. So this is my question, but I want to say something, and maybe in the end you can answer this one. So if we look at, I mean, US is a capitalist country. Okay, I'm not. It is not an offensive statement. It is, it is a fact, and I don't mean offense. So, and many other countries are capitalist countries, and we look at few things. For example, smoking. Every year, more than 100,000 people die in UK alone. 100,000. I don't know if people will believe. 100,000 is divided by a week. You can calculate how many people die every week. And they die because of smoking-related diseases. And it costs them, the NHS, it costs billions of pounds to deal with those diseases for the population. Now, if someone sit down and think that this is something which is causing 100,000 people to die in the country, shouldn't we do something about it? But we don't do it. Rather, we write, smoking is injurious to your health. And then we export it to many countries. And the underdeveloped countries, actually, there are many more people are dying there. And also, they are spending a lot of money on buying something which is a disease. I'm sorry if there are any smokers here. I'm not talking about the smokers. I'm talking about the smoking itself, you know, the cigarette. So then we come back to cars. In US, 42,000 people die every year because of car accidents. And this is the deaths. And then you have injuries in millions. And if you look at all over the world, the number is very large. And Saudi Arabia is one of those countries where a lot of people die. Now, if we go back 50, 60 years or whatever years back when we started using cars, and we start talking about this, that should we use cars or not, because after 50 years, we will kill 42,000 people in this country alone. So coming back to EHRs, what is the option and why are we coming to EHR? Simply because there is a big chance of error when people are writing by hands and a lot of things. And the idea is that we can get that information in written form and we can minimize the errors. So that's one of the ideas. The second idea is that you have much more information available for you to make a decision. So there is a good reason for introduction of EHR. And we know, I'm concluding now, and we know that it is a capitalist globe we are living in, and it is run by the companies, you know. And companies decide what is going to happen, and it is about money, and then many politicians are involved in these companies, and therefore they make decisions. So it is a question, although I feel that it was a political problem, it is a question that whether you meant that it is a political problem of implementation or EHR itself is a problem. And then, you know, what would have happened if actually the EHRs were implemented properly. And also we need to keep in mind, when you are answering this question, we need to keep in mind that actually now we are living in time where we are, what we call it, customer co-design. Co-design, that we are designing things in collaboration, in working with the customers, with the people. So isn't it better that EHRs were introduced and therefore it is being designed with patients and doctors, and we are finding out what the errors are? Of course, we should minimize the errors and we should try to avoid that.
So let's go back to the early days of Microsoft DOS, the operating system. I guess everyone in the room knows what that is. Microsoft DOS. Let's suppose that when Microsoft DOS had been introduced, someone like you was in a position of power, and they said, well, this is really fantastic. Look at all the things we can do. Let's mandate that every computer has to use Microsoft DOS. That's what happened with, well, someone like him. Let's mandate that it has to be used, and after 5 years, anyone not using it will be fined. That would have been a crazy decision. You agree? Now, I say yes. Now, something like that decision happened both in the US and in the UK because politicians and their scientific advisors were looking at the wonderful things we can do with these newfangled computers. So let's mandate that what we have now becomes compulsory. That was a mistake, and the scientific community should have immediately created a gigantic response saying, no, we're not mature, we need to test these things. Not to stop them from being introduced, but to stop them from being introduced across the whole country. That's the idea I'm proposing. Now, the British Computing Association did indeed try to do that. So they organized a lobbying effort to stop what they saw as an effort by Tony Blair to mandate the use of this is socialism now, of a single medical record system to guarantee interoperability. It was a disaster. So the system was housed in one building in Middlesex. It was compulsory to use just that system. Hospitals were not allowed to have a medical record system. They had to use the one in Middlesex. But they all realized that if the telephone wires to Middlesex would go down, they wouldn't have access to their medical record system. So they all built illegal shadow record systems within their hospitals, so thereby immediately doubling the cost. Moreover, the Tony Blair system mandated that you could only use certain companies for entering data into the system in Middlesex. And so any computational activity in a hospital had to be carried out by one of the 4 regulated allowed companies. The cost of installing Microsoft Word on a computer went up 4 times because these people had a monopoly, another cost. So the scientists in Britain tried to fight this, the computer scientists tried to fight it because they could see it was a mistake, but they were too late and they were too lacking in articulate people like you who would go up and wave the flag and scream and tell them that they were making a mistake. Now, I'm coming along very late now, so I'm trying to wave the flag and scream for the next episode, which is going to be the genome. Introducing genomic methods into hospitals is going to bring about, I predict, the same sorts of mistakes. So I'm warning.
Good. In the interest of the coffee break, please help join me in thanking all the speakers for this fantastic session this morning. And I will give this. And I will see you at 11 o'clock for another dramatic session of science. Thank you for coming.